okay, what I'm teaching to students and to the patients as well is to try to really prevent this to happen. That's the best, the strongest weapon we have is to prevent this to happen, because once it happens, it's nearly impossible to go back. Now, if we look at the history of and the prevalence, how many stroke, how many heart disease, how many deaths of cardiovascular disease we have, since 1995, there has been a significant improvement in the prevalence of this event. So things are improving a lot. And this is true for the general population and also the population of patients with diabetes. And what has happened? Basically, we had two major classes of drugs that were introduced in the late 80s, 90s. One is the statin to bring cholesterol down, and one is a drug that we use for hypertension. The target a part of this, the inhibitor of the renin-angiotensin system. Is difficult. So these drugs are called ramipril, lisinopril, or losartan, candesartan. This is the same. And these have been crucial because they are really protective for different mechanisms of the heart, the kidney, and the vasculature per se. Starting by reducing the cholesterol, which we know is very bad for your vessel. Since the 90s, nothing has really happened. But at the end of our chat, I will introduce you a new drug that has been introduced in the last 3-4 years, which I think will contribute significantly to a degree of like the statin at the time, of this other blood pressure tablet that were introduced in the 90s, and will make a difference in the decades to come. Now, our research started in the Unit for Metabolic Medicine, which is a group that at the time was a Guy's Hospital, the United Medical Dental School. And this was a group of Harry Keene, who passed away a few years ago. I met him. He's a fantastic professor, really, probably the best I've ever met. And his junior fellow was Professor Liberti, who is now retired, and he was my boss. And then I had the unit at the moment. Now, the story goes back with Professor Harry Keene, who discovered microalbuminuria, or difficult name probably. Just to tell you, he was looking into the urine to find something that could indicate to doctors that something was going wrong with the kidney. And he identified these things called albumin. Albumin is a molecule, is something that circulates in the blood, and it usually does not go into the urine. And if you find it in the urine, it means that your kidney, which is a filters the blood, is leaking. Imagine the filter of a machine. When it leaks, it doesn't function very well. So it means that your kidney doesn't function very well. And if you think as the kidney is a vessel, basically, imagine it as a filter, a big vessel that filters the blood. If that is damaged, there is a theory that has some data that supports this, that if the vessels of the kidney are damaged, probably all the vessels in your body are also damaged. So the presence of this protein in the urine called albumin could suggest that that specific patient or individual had some damaged vessel. And after this Harry Keene and Giancarlo Viberti, my boss, and many others around the world, did a lot of studies in looking at whether the presence of this protein in the urine could represent a marker, something that could tell us, oh, this patient is at risk, this patient is impaired, so we need to follow the patient more closely, we need to be more tried to deliver a more intense care and make the patients understand that there is some risk factor. And actually, it turns out that the presence of this protein in the urine correlates very well with the fact that patients who had the protein in their urine were more prone to develop for example, a heart attack, or the kidney function could deteriorate, or the survival was shorter than patients who didn't have this protein in the urine. So it was a fantastic marker, and a marker, as you know, is a marker when it's easy to measure, so can be measured everywhere, it's cheap to measure and accessible. And so this is something that we now measure with every patient. It's measured in GP practice, it's measured in hospital. Of course, if you think about it, it's not the perfect market, and I won't go into many details, but it gives us a lot of information on what is happening to the patient. So I was involved when I first joined the group, and this was in 1993, about 25 years ago. In a lot of work on this with patients, and my interest suddenly went on the kidney. My previous research, I was in the United States, in Boston, and I was studying molecules that transport the glucose into the cells, which are very important in the mechanism that then results in the development of diabetes. And so I became a kidney man, basically. And what I do today is looking after patients with kidney disease and diabetes in all sorts of scenarios. So we looked a lot during these past many years, both in patients and in experimental animal model. We do a lot of research in animals to try to identify new marker, new mechanism that could be involved in kidney disease. Because if we understand more, then we can develop new targets. And we had a lot of candidate genes and candidate protein, and many of which didn't tell us much. And we're now working on the protein, which will touch base later on. Let's go back to the patients. I said that I'm very interested in kidney disease, but what you need to know is that when the kidney doesn't work, and you have albumin, this protein in the urine, your vessels don't work, your heart doesn't work as well. So kidney and heart go together. So the presence of this protein in the urine was a really important information for the doctor. And heart disease is, at the end of the day, one of the major problems that cause of death in patients with diabetes. Now, how do we prevent this to happen? Because that's the key. We don't want these complications to progress. We want them to improve. And really what I tell to patients is, one, okay, you need to control your diabetes. Now, there are different ways to control your diabetes. Lifestyle changes, diet, exercise, and then we have some tools, some oral tablets, and some injectables that we use that help us doing this. Now, but is a better glycemic control important in preventing the complication, this disease of the kidney, disease of the vessel, disease of the heart? Well, the answer is yes, but there's only one study which was done in the United States in patients with type 1 diabetes, which were divided in two groups, a conventional treated group at the time, and one very intensive, very tight glycemic control group. And this was insulin. Insulin treated, of course, is patient with type 1 diabetes. And of course, what the study was the DCCT, don't know if you heard of it. the results were that, of course, a patient with a better glycemic control did much better in terms of cardiovascular outcome. But this was after 10, 20 years. So really, vascular complications take a long, long time to develop. And this study was successful because we knew at the time when the diabetes started, day 0, and then we followed the patient for 20 years or so. So that worked. There was a study conducted in the UK in type 2 diabetes. That was the UKPDS. That was in the end of last century, which suggested similar results. But when you speak about patients with type 2 diabetes, when you diagnose patients with diabetes, with type 2 diabetes, we are already late because probably diabetes has started, or a pre-diabetic state being in between normal and diabetic starts probably 10 years before. And that's why when we diagnose diabetes for the first time in a patient with type 2 diabetes, we still produce insulin, but the insulin doesn't work very well. These patients already have developed a degree of vascular complication. They might have a little bit of retinopathy. They might have a little bit of albumin in the urine. They might have some peripheral vascular disease, a little bit of hypertension. And so we start a little bit late. So it's crucial, or we have learned many in the study with patients with type 1 diabetes, to intervene as early as possible and maintain the best diabetes control possible. Now, one might ask, okay, I was a bad patient, I was young, I was partying, I was eating anything, we didn't look after my diabetes, but now I'm much better. So things could go better. Well, yes, certainly will be better, but remember, there is a metabolic memory. The body remembers the bad days, unfortunately. And this is true only for glycemic control, not for blood pressure, strangely enough. So what I tell to my patients, the better, the earlier we intervene in achieving the best possible, because we're not machines, we need to compromise a little bit with life, the best possible glycemic control, then that will bring you in the future with good news and will prevent the development or the progression of already existing complications. And this is crucial. Of course, we have medication that independently of glycemic control can help you with the complication. And these are inhibitor of the renin-angiotensin system I was mentioning to you. These are blood pressure medication. And this is first-line treatment in patients with diabetes and also without diabetes. This is true also in the non-diabetic population. And if we speak about blood pressure now, that's the other important thing. So we said glycemic control is important, and the body remembers the bad day. So better start as early as possible to control your diabetes better. Blood pressure. Blood pressure is also very important, especially for the kidney. And we did some studies, both in animals and in cells in vitro. And we understood that in diabetes, there is a dysregulation of the vasculature in the kidney. And what happens, not only there is a metabolic insult, and by metabolic insult is elevated glucose circulating level, but there's also a hemodynamic insult. Like the blood pressure transmits on the vasculature of the kidney in a patient with diabetes, more with a worse effect than in a patient without diabetes. And so it's very important to control blood pressure. So poor glycemic control and a high blood pressure in a patient with diabetes will destroy the kidney, will destroy the heart. That's the worst that can happen. So blood pressure needs to be controlled very well. And there's no excuse for that, because if it's too high, we add the medication. If the blood pressure is still high, we increase the dose of that medication. If it's still too high, we can add another medication. So as doctor, we cannot have. While it's very difficult to achieve a good metabolic control, we cannot have any excuse, us and the patients together working in controlling blood pressure. And I tell you that that is very, very important. Now, what is the target for blood pressure? And here's another story. New guidelines 2 or 3 years ago from the United States, they say that the new normal blood pressure is a blood pressure less systolic, less than 120/80, which is a pretty low blood pressure. So everybody's hypertensive here, myself as well. So, and there was a big issue in the United States, especially for insurance. What is high blood pressure? You already have high blood pressure, so the premium goes up, a mess. And at the end of the day, that was actually the clinical studies said, the tighter the blood pressure control, the better your outcome. But what was the side effect? A dizzy patient, an elderly lady falling and breaking the femur, some electrolytes, sodium, potassium problems. And so I think we need to take a pinch of salt how we work. And we now aim for a 130/80, sometimes a little bit higher, because some patients, by being too tight, they feel dizzy, they cannot stand. And that's because maybe their vasculature is a little bit damaged. And also we cause, by bringing the blood pressure too low, possibly a hypoperfusion. So pressure low, maybe the blood won't go into all the little vessels which maybe are a little bit damaged. And there are some studies, and we also observe this, that if you are, say, over 65 years old, and your chance, your mortality improves, so you die less if your blood pressure is lower, to a degree of, say, 135. If you bring it lower to 120, the systolic, the high number that you see when you measure, if you bring it too low, then your chance of dying increase again. So it's like a J effect curve, goes down and then up again. So for some patients, especially the elderly, we need to tweak it a little bit and not be so aggressive. Of course, in a 20 years old, aggressive. But in a 70 years old gentleman or lady, maybe not as aggressive. And the same is true if the patient has a kidney that works or doesn't work. And the thinking is the same. If the kidney works, it's likely that all your vessels in the body and the heart are happy. But if your kidney doesn't work and you have a little bit of albumin in the urine, which suggests that the vasculature is damaged, then also your heart is probably not as happy and your vasculature is not as happy. But certainly blood pressure control is very, very important. If your systolic, which is the high number when you go to your doctor and you measure your blood pressure, is above 180, you probably are losing 10% of your renal function in 1 year, which means that in 10 years, you're on dialysis. If your systolic with a high number of the blood pressure is about 130, you physiologically lose, as we all get old, 1%, 1.5%, and your kidney will last for all your life. So this is very, very, very important. So we are controlling glycemic control, we are controlling blood pressure, and now we can control very well cholesterol with the statin. And they really have made quite a difference. Now, there was a study, again in the 90s, this was in Denmark, a good friends of mine, and it's called the STINO2. What they did, they randomized some patients with type 2 diabetes to the current, they did a study. So let's compare patients that are treated the way they are treated now. So this patient had a, at the time, I don't know, what was at the time, ex-diabetes control. They were eating what they were eating, bacon, salt, beer, Danish diet, good beer for sure. And so that some of the patients, they left this way. The other group, the unlucky one at the time, they said, okay, exercise, lose weight, stop smoking, no more beer, stop eating salt, salads, boring, carrots, and all these things. And they compared them for 3 or 4 years. And they measured outcome. How many times they had a stroke, how many times they had these were all diabetic, type 2. Compare about the heart problem, if they had a bypass, if they had a peripheral vascular disease, if they had an ulcer in the feet, they looked at the kidney and the eyes, and etc. Well, of course, the one in the intensive intervention did very, very well. Let's ask you now, the intervention were aimed at improving lifestyle, blood pressure, glycemic control, lipids. How many of these patients achieved a lower cholesterol level? All of them, with the statin. How many of these blood pressure achieved a more, say, aggressive blood pressure target? All of them. How many patients achieved a better glycemic control? They were the same. Means that it's very difficult to improve diabetes control. Nevertheless, by targeting blood pressure, lipids, lifestyle, sometimes weight, etc., we still can make a difference. So don't be desperate. That doesn't mean that we need to intervene more on the glycemic control. Now let's go on the most recent research. There is one new medication. These are SGLT2 inhibitors. I'm sorry, I'll tell you what it is. Little bit of physiology, easy physiology. The kidney is a filter. It filters blood, water, glucose, salt, and after the filter there is a long tube. And in this tube, things are reabsorbed and there's all regulation, and you have everything in the urine. In normal physiology, you filter a lot of glucose all the time, but it's all reabsorbed back. So you don't have glucose in the urine, okay? In diabetes, because your sugar in the blood is higher, you filter more glucose. And the body thinks, oh my God, I'm losing nutrients, I'm losing calories. So the body upregulates the system in the kidney that brings back the glucose that is filtered. Still, there will be some glucose in the urine because it's so much. So when you have diabetes, you have glucose in the urine, you pass more water, and etc. So these drugs are counterintuitive. They fought. Well, why don't we try to improve the diabetes by making the patient pee more glucose? So they have developed this drug, which are, you might have heard, dapagliflozin, canagliflozin, empagliflozin, flozins. And these drugs block the reabsorption of glucose. So suddenly you pee more glucose, you lose calories, you lose weight, and your diabetes improves. Okay. Surprise, surprise. Since probably the last 15 years, the FDA and the European agency have asked for all medication for treatment of diabetes to do some parallel cardiovascular outcome trials, so studies to evaluate whether these drugs were safe from the cardiovascular point of view. Because there was a story for some class of drug 10 years ago, the PPAR agonists, that were possibly causing some increased cardiovascular death, which then didn't, but since then that's the case. And of course, all the new medication for diabetes that were coming out, and there have been few in the last few years, they are all neutral, okay, yeah, good, improving diabetes, but on the cardiovascular system, there wasn't much of an effect. But surprise, surprise, these new drugs have, in few words, have a very important benefit for the heart and the kidney. And I tell you, it's since 1990 that we didn't have any drugs to protect the kidney in patients with diabetes. Now, the effect we see, and we did some small studies at the beginning to look at the mechanism of these drugs in patients with diabetes. These were done in conjunction with industry. These drugs, the effect we see, improvement in renal function, improvement, a reduction in the fall in the function of the kidney, or improvement in the outcome from poor heart or cardiovascular death, occurs after 1 year, 6 months to a year. So it's not driven by an improvement in metabolic control. I told you before that to have an effect of metabolic control on complication, it takes 10 years. Now here we see the effect after 1 year. And so it's not driven by the hypoglycemic effect that these drugs have on patients with diabetes. It's something else. And there has been a huge amount of studies trying to understand this. Recently, trials have looked at the effect of these drugs in patients without diabetes. And indeed, they work. So they work in patients without diabetes, and they protect the kidney function, the heart function. So it's a revolution. This medication is now in our guidelines with metformin or just after metformin for treatment with diabetes. I think it should be put in the water for everybody. And so we drink it every day. It's really a significant effect. And we've done a lot of study to try to understand the mechanism of this. I wouldn't go into many details, but to see whether they activate other pathways that are protective for the vasculature, and indeed they do. They modulate the expression of some factor involved in inflammation, which we know is increased in patients with diabetes. It's not inflammation driven by a bug or anything. It's a septic inflammation that we know is in the vasculature of the patient with diabetes and is driven by the elevated glucose. And so this drug is now on the market, and we've been using for a few years now, and it will be probably used more and more. We, of course, need to understand more and more. The last things I want to mention to you is what we are doing on the experimental side. We have recently identified a protein, which we call no-go-B, no-go, don't go, so, but I'm studying it. And it was found by chance approximately 5 or 6 years ago in a little mouse, which is not a human. And we did a lot of studies, then we did some studies also in biopsies, of renal biopsies of patients with biocollaboration, because this is biopsies, as you know, is not a routine. So collaboration with different patients and biobanks, both in Europe and in China. And this protein is indeed downregulated in diabetes. And we know that this protein is good because it makes your vasculature happier by acting on specific pathways. And so if your kidney, for example, is leaking albumin, if we in some way activate this protein, this pathway, we make the kidney less leaky, and probably we make all the vessels happier. So, and to close, you probably understood this. I do very few aspects of the research, but there are, of course, many other groups doing other aspects. but the treatment of diabetes is a marathon. You have to start from the very beginning, and then slowly you try to prevent. Prevention is key. When it's there, we cannot go back. Although academically there are studies that suggest you can go back, but it takes a long time. As you develop a complication, it takes 20 years. It might take up to 20 years to go back, and then you probably, if you're 80 years old, you probably don't have it at 100 years old. But anyway, so prevention is key, and there's certainly a lot of work to do. But I have to say, since I was a student, what I see now is way much better in terms of treatment for patients with diabetes, and certainly the tools we have are really, really much better. So I'm sure for the student of today, when they'll be my age, there will certainly some more for the patients to be. Maybe me as well, because my dad was diabetic, my grandfather was diabetic. So I'm next in line, I think. Okay, so that's it. If you have any question, happy to answer.
Thank you so much, Luigi. That was very engaging, informative.